Hello and good evening, everyone. Thank you for joining us for tonight's event titled Diagnosing Allergic Conjunctivitis with Dr. Elise Kramer. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So I'd like to introduce our amazing speaker tonight. You probably have heard her speak before. She is just lectures all the time and is an amazing speaker. She is a residency trained optometrist who has her own practice in Miami, Florida, and specializes in ocular surface disease and specialty contact lens fitting. She received her doctorate of optometry from the University of Montreal in 2012. And she completed her internship at the Eye Centers of South Florida and completed her residency at the Miami VA Medical Center. Her time training at the Bascom Palmer Eye Institute, which is one of the nation's top hospitals. She learned a ton there, and after her residency became a fellow of the Scleral Lens Education Society. And you're the secretary for SLS, right?
Treasurer, it's true. Thank you for pointing it out. I saw
Yeah.
the same time. I was like, yep, treasurer now. So
yeah, board member. And now serves as the public education chair-elect for the, so we're super excited to hear from you tonight, and thank you so much for joining us.
Thank you for having me. I'm very excited to talk about allergic conjunctivitis. Tis the season, right? To talk about it. This is definitely a hot topic right now, at least across the US. We've got a lot of allergic conjunctivitis going on. And I'm sure whether you have a primary care practice or an ocular surface disease practice or a contact lens practice, you are definitely seeing this. And actually, so I'm going to talk a little bit about allergic conjunctivitis and go through it, kind of how it happens and then how to diagnose it properly. And also, we're not going to focus too much on treatments because that will be discussed eventually at another CE course. We're going to really be talking about diagnosing it. So allergic conjunctivitis affects 20% of the population. So it's definitely a big deal and it's very common. Symptoms, the most common symptom is going to be pruritus or itching, redness and swelling. And it often occurs with nasal symptoms as well. So people sneezing or runny noses. And what's important about allergic conjunctivitis is that it definitely significantly impacts the quality of life. And that's been shown in a lot of retrospective studies, surveys, and it's across the board. So it's often underdiagnosed and undertreated. And I think that's why it's important to have this type of course, because we as eye care practitioners, it's important for us to diagnose allergic conjunctivitis, but it's also important for other providers to be able to at least know what to look for, because so many other type of providers see patients with allergies. Only 10% of people who have allergic conjunctivitis or have symptoms of allergic conjunctivitis actually seek medical attention. So most people are actually managing their symptoms with over-the-counter medications and complementary non-pharmacological remedies. So actually that's interesting because a lot of the medications we use to treat allergic conjunctivitis are actually over-the-counter. But if a patient doesn't know which one to choose, they might choose the wrong one, or they might choose something that actually doesn't help with allergic conjunctivitis. And again, some non-pharmacological remedies may or may not work because there's very few studies about those. So successful management is really overcoming the challenges of underdiagnosis and misdiagnosis. So we'll see why that happens so frequently, but allergic conjunctivitis is not diagnosed often enough, and it is often confounded with other things that it is not, or it can actually happen at the same time as other conditions, but it's not identified properly. So in order to really get the diagnosis correct, it's important to understand the subtleties history, do a proper comprehensive examination. What are appropriate diagnostic procedures? We'll talk about those. And cross-referral between specialists. So this is something that I think eye care specialists and allergists should work a little bit more on together, because as we see the diagnosing procedures, a lot of it is not things that we do in eye care, but that are pretty important to do in order to identify allergens. And so that becomes important when diagnosing allergic conjunctivitis in order to properly treat and overcome. So the ultimate goal is to overcome the unmet needs in global health, just like many conditions, of course. So allergic conjunctivitis commonly overlaps with other anterior ocular diseases. So dry eye being probably the main one. As you can see there in this Venn diagram below, there's a huge overlap in symptoms. People with allergic conjunctivitis and dry eye both have dryness, feelings of dryness and itchiness. And so just having those symptoms alone makes it difficult to identify whether the patient has dry eye, allergic conjunctivitis, or both at the same time, because of course they can both occur at the same time. And then you can have infectious disorders as well, and we'll go through them. And as I mentioned, dry eye. So it's really important to diagnose this, because misidentification in the primary care setting actually leads to inappropriate treatment. We as eye care providers, we know how to diagnose allergic conjunctivitis in the primary care setting, which a lot of patients actually go to. And when they do have these symptoms, they're not being identified as having allergic conjunctivitis. They might be identified as having dry eye or bacterial conjunctivitis, but not allergic conjunctivitis. And this diagram here at the top, it shows what happens over time if allergic conjunctivitis is not identified and not treated. So if you look at hours in the middle, we see that at the beginning it's pruritus, erythema, chemosis, edema, so just swelling, itching. But then days to months, we do have reappearance of initial symptoms and also disruption of the ocular surface. And then months to years later, you can have actually visual consequences, ocular surface damage, and just continued inflammation. And inflammation, as we know from a lot of talks that we've done on dry eye, if it's not properly located, or if it's not properly treated, then it will just perpetuate, and it's a vicious cycle. And the same goes for any type of inflammation if it's not properly treated. So let's talk a little bit more about misdiagnosis. If we look here at the table at the bottom, this table is more what to look for and how to know if this is not allergic conjunctivitis. So anyone with corneal opacity or fixed coming in with this reason, fixed pupil, severe headache, photophobia. And obviously these guidelines are a little bit more for primary care, but I think it was important to know really what are the signs that this is just probably not allergic conjunctivitis. So decreased visual acuity, ciliary flush, which is probably, it could be infectious keratitis, uveitis, angle closure, different things like that. So the red eye is what's confusing, because red eye can mimic so many different things. But we know that in eye care, the physical examination involves flipping the eyelid. I think this is so important. I try to do this on almost every patient. I have a contact lens practice, so this is something I do on almost every patient, but I really encourage people to flip more eyelids. And of course, this is the main way that we diagnose allergic conjunctivitis, is we flip the eyelid. You can use a Q-tip. That's probably the best way to do it. And then you can see different grades of papillae on the Efron scale below. And we use those to grade it and then monitor treatment, progression of our treatment. And of course, elimination of the allergens. So again, flipping the lids, very, very important. And we'll talk about that a little bit later. So how does allergic conjunctivitis actually happen? Well, like any type of allergy, you have exposure to an allergen, which creates IgE antibodies, or makes IgE antibodies stick to a mast cell, and they stay there, and they're kind of dormant. And you've got granules containing chemical mediators that are kind of just there. And obviously, this is a video showing allergic rhinitis, but it's very similar. On secondary exposure to the allergen, it creates this reaction where the allergen actually sticks to the IgE, releases inflammatory mediators, and binds to histamine receptors, releasing histamine and causing just all of the signs that we were talking about. So swelling, itching, redness, and just overall itching, discomfort. So let's talk about, again, the red eye. So differential diagnosis. This is a very exhaustive list of everything that can cause something that looks like allergic conjunctivitis. So we go all the way to the left, and we see that the eyelid is involved. It's most likely, blepharitis, like eyelid swelling, so blepharitis, or bacterial just conjunctivitis, but affecting the eyelid. And then, of course, you can see when it's allergic, we talk about chronic, which we'll talk about, again, vernal, atopic, or giant papillary conjunctivitis, and then acute, which can be seasonal, which basically fluctuates based on what season it is, and perennial is an environmental or exposure to something in the environment, but not necessarily related to the season. So like dust, or like plants or pets, things that can be around all year. And then if we see, again, the conjunctiva involved, we're thinking infectious. So if it's infectious, it can be viral, bacterial, parasitic, fungal. And if it's immune, it could be autoimmune or immunodeficiency. And of course, if it's affecting the lacrimal gland, we're thinking of dry eye. So the aqueous deficient dry eye category. So again, when we have a red eye, it's important to identify whether it's allergic, whether it's dry, whether it's infectious. And it's very important to identify what the diagnosis actually is in order to apply the appropriate treatment. So one thing that really is important, and I was talking about averting eyelids, is the difference between follicles and papillae. So follicles consist of hyperplastic lymphoid tissue, and they appear different than papillae. So you can see it in the diagram, they do not look the same. And what I use most in clinic is when you look at follicles, they're actually surrounded by blood vessels. And you typically will see this in adenoviral and also chlamydial disease. You do not see this in allergic conjunctivitis. Papillae, if you look closely, you can actually see the blood vessel inside, like in the middle of it. And that is the best way that I have used clinically to differentiate, because they do kind of have a similar appearance. And papillae are usually seen with bacterial and allergic conjunctivitis. And again, when we focus on allergic conjunctivitis, it's important to know the difference between follicles and papillae. That's often present very similar. So let's talk about evaluating and different studies for seasonal, intermittent, and perennial persistent allergic conjunctivitis. So intermittent obviously means it comes and goes. Persistent is it continues on. So the skin prick test, this is not something that we do in eye care, but it's important to talk about. So it's simple, rapid, and inexpensive. And what it gives is evidence of a specific sensitivity to an external environmental allergen. And what's good about the skin prick test is that it actually gives these results within 20 minutes. So very fast. It's highly sensitive for systemic allergies, such as allergic rhinitis and allergic asthma. But what's important to understand is that it doesn't always correlate with allergic sensitization of the ocular surface. So just because you're getting a reaction on the arm from a skin prick test does not mean that that is what's causing the allergic conjunctivitis. But it could be a good test to kind of help identify, but it doesn't always correlate, and that's important to understand. Another test is the patch test. So this is good to do in the presence of eczematous blepharitis or blepharoconjunctivitis. Again, we don't do this in eye care, but this is what I was talking about earlier of co-managing with allergists, because if you have a good relationship with an allergist and you identify a patient with allergic conjunctivitis, we can treat that. Of course, we have definitely a lot of over-the-counter medication and prescription eye drops for this. But the main thing we want to do is also identify what the allergen is, because elimination of the cause or elimination of the allergen itself, the underlying cause, is going to be the ultimate treatment. So the patch test, again, is not something we really do in eye care, but this type of test is for a delayed type of reaction. So we will get results of this at about 48 hours. And it may be a necessary test to actually identify the specific allergen. And we see a lot of BAK and thimerosal delayed reactions. And you can actually perform this type of allergy patch test to using the actual solution that you're maybe suspecting is causing the allergic conjunctivitis. So you can see what positive reactions look like. So you have the weak positive, the strong positive, and the extreme positive. And like I said, you can actually use the solution. Let's say you think it's a solution that's causing the allergic reaction, you can actually use that solution in the patch test. Patch test is done on the back using aluminum or cellulose discs. And what's important to understand is that the skin on the back is very different from the skin on the eyelid. Skin on the eyelid is a lot thinner. And so you can have something react a lot more on the eyelid than on the back, but this is the way the patch test is done. So let's hone in on thimerosal for a minute. So this has the highest frequency of cell-mediated responses of all ophthalmic preservatives. It is most commonly found in soft contact lens solutions, and it does cause delayed hypersensitivity. So this is where the patch test comes in. Then we have a conjunctival provocation test, or a conjunctival allergen challenge. And this is like a skin test of the eye. So very quick test. Basically, you apply known quantities of specific allergen onto the ocular surface, and you will get the response within 15 to 30 minutes. The media release and cellular infiltration are pretty easily measured in tear samples. And a lot of this is used actually in research and to assess new drugs. And it's what we're doing in this test, which is different from the skin prick test, is actually we're using allergens that are limited to the ocular surface. So that may not actually cause any reaction in the rest of the body, but it is causing in the ocular surface. And obviously the positive response would be the same as exposure to the actual allergen, which is chemosis, papillae, and symptoms. So the positive reaction usually subsides pretty quickly within 20 minutes, but you can also have a late phase inflammation, and depending on the patient's sensitivity, but it is pretty safe and simple procedure. And it provides valuable clinical information and also very limited systemic reactions. As I mentioned, it is sensitivity limited to the ocular surface. And so it doesn't really cause any generalized itching or bronchospasms or anaphylaxis. So let's talk a little bit about how to differentiate allergic conjunctivitis from other things that may mimic it, such as dry eyes. So these are different tests that you can do in the office. So finally, something that we do in eye care. So the box at the bottom, or the test at the bottom, will actually measure the IgE in tears. And IgE is really, really low in tears. It should be less than 3.5. And so if your number is higher than 3.5, then that's actually telling you that you have allergic conjunctivitis. So you can actually get this test and do it in your office. And the two tests that you see above are tests that are used for dry eyes. So you have the osmolarity test at the top and Schirmer test in the middle. And basically these tests will, the first one, the osmolarity, will allow us to determine whether there's inflammation caused by dryness or hyperosmolarity, which you see in dry eye and not allergic conjunctivitis. And the second test is the Schirmer test, which a lot of us are familiar with. The Schirmer test is a test that measures basal tear production. So if it's less than 10 millimeters, then the person does have a relative aqueous deficient dry eye. And so again, if you get a high osmolarity, or if you get a low Schirmer's score, then the person probably has dry eye. If you get a higher than 3.5 IgE, then they probably have allergic conjunctivitis. People can have both conditions at the same time. So that's important to take into consideration. But if you can identify one or the other or both, then you can treat them, and that's key. Now, different staining procedures that we can use hold on, let me go back, in eye care. So I love these procedures because they're easily done in an eye care setting. So when we're looking at papillae, one thing I like to do is use fluorescein, and you can see how well fluorescein delineates papillae. You can really, really see them a lot better. The photo at the top, if you compare A and B, you can see how much better delineated they are with fluorescein. And then lissamine green is a vital dye that will stain dead and devitalized cells on the conjunctiva and cornea. It does not stain the tear film or it does not show the tear meniscus like fluorescein does. And it's a very important dye that I like to use in dry eye. So this is a good tool to differentiate also between dry eye and allergic conjunctivitis. What you see in this photo with lissamine green is called lid wiper epitheliopathy. And we see that a lot in moderate to severe dry eye, and also a lot of contact lens wear. So it shows the friction between the palpebral and bulbar conjunctiva. And rose bengal is similar to lissamine green. The difference is that rose bengal does sting a little bit, but it also does the same thing. It stains dead and devitalized cells on the conjunctiva and cornea. It does not measure the tear meniscus, or it does not stain the tear meniscus, so you can't use it for that, but it's very helpful test. I think in general, most people use lissamine green now. And then we have another test that is actually taking cells from the conjunctiva, which we can, if you have a pathologist or you have a lab that you use, you can actually, it's called conjunctival cytology, and you can actually look at cells and determine whether there is inflammation or not in the conjunctiva. And you can see eosinophils. So one thing about allergic conjunctivitis is that eosinophils play a huge role. And a lot of allergic conjunctivitis conditions, which we'll talk about, have a high presence of eosinophils. So identifying those could be very indicative of allergic conjunctivitis. So let's talk about different chronic allergic conjunctivitis conditions. So VKC, or vernal keratoconjunctivitis, characteristically affects young males in hot, dry climates in a seasonal manner. Actually, vernal means frequent springtime onset and exacerbation. So that's exactly what the vernal is in VKC. And I was just talking about impression cytology. We're talking about eosinophils, and that is an important part of the pathogenesis of VKC. So let's talk about different signs that we see on the eye with VKC. diffuse conjunctival injection on upper tarsal giant papillae, cobblestone papillae, often called. So they're greater than 1 millimeter in diameter. They usually have a flattened top, and they can also stain with fluorescein. And they can be seen also near the limbus. So if we look at the limbus, we've got thickening and opacification of the limbal conjunctiva, gelatinous appearing and sometimes confluent limbal papillae, like you can see in these photos. Perilimbal Horner-Trentas dots are focal white limbal dots consisting of degenerated epithelial cells and also eosinophils. And if you leave this untreated, what can happen is limbal stem cell deficiency. And that is a big deal because that can actually become sight-threatening with pannus formation, neovascularization. So again, perpetual inflammation, if it's not treated, can lead to vision-threatening conditions. Another vision-threatening issue that can happen with VKC is this type of ulcers, which vary according to the severity of the disease process. You can actually get punctate epithelial erosions or keratitis, which can coalesce into macroerosions of the epithelium. And these plaques, which are called shield ulcers, can contain fibrin and mucus, and again, cause these macroerosions. Again, corneal neovascularization can ensue and can leave a ring-like scar. And that's very, very prominent in VKC. Giant papillary conjunctivitis is another chronic inflammation or a chronic papillary allergic conjunctivitis. And this is associated with continuous contact between the conjunctiva on the upper eyelid and a foreign body. So it can be an ocular prosthesis, it can be an exposed suture from a surgery like a corneal transplant or a cataract surgery, or very commonly contact lens. And I was talking about before, being in a contact lens practice and just constantly flipping eyelids, you will see conjunctival papillae in a contact lens practice. And the more, the thicker the contact lens is and the longer amount of time that the person has been wearing it, the more likely they are to have papillary conjunctivitis. So the papillary conjunctival response is, again, fine, this time less than 1 millimeter though, elevated polygonal hyperemic areas, and it looks like a mosaic on the eyelid, and it can also be seen on the lower eyelid too. So also often evert lower eyelids as well, especially in kids. So a lot of kids have a little bit of discomfort when you try flipping the upper lid, or they're afraid. And so the lower lid can give you a lot of similar information as well. When we talk about atopic keratoconjunctivitis, this is another chronic inflammatory disease of the eye that affects patients with atopic dermatitis. So a lot of these patients have eczema. They'll have those Denny's lines, erythematous, just thickened dry skin, tylosis, and they'll have blistered patches. So a lot of these patients are actually going to be taken care of simultaneously in dermatology as well. These patients, because they have so much eyelid involvement, will also have meibomian gland disease. So again, a lot of dry eye and allergic conjunctivitis at the same time. Again, because the eyelids are so involved in this type of reaction, you can have a lot of meibomian gland dysfunction, which needs to be treated separately, and is very common. So, but you can have other eyelid findings as well, like tropion, trichiasis, matarosis, and this more frequently occurs in adults. So if we look at the conjunctiva, it will be hyperemic, edematous, prominent tarsal papillae, mucoid discharge is often present, and severe conjunctival disease can result in scarring, symblepharon. So again, just perpetual inflammation leading to chronic signs and visually threatening problems. Horner-Trenthass dots can be present as well, may or may not be present. The cornea, unfortunately, involvement is frequent. So it can range from punctate erosions to full ulcers and even perforation in these patients. So these are very severe allergic patients. And peripheral vascularization is common, pannus is common, and these patients actually more commonly have anterior subcapsular cataracts as well. So contact dermatitis, another type of, this is a cell-mediated delayed type hypersensitivity reaction, which can lead to blepharoconjunctivitis. So this type of reaction is involving mostly the eyelids. You can sometimes see papillae still on these patients, but it's mostly an eyelid issue, a skin issue, and it generates significant swelling. And even if there's minor degrees of inflammation, you can see like a huge reaction on the eyelids. And usually it's going to be caused by cosmetics that are applied to the face, the hair, the fingernails, or fake lashes. I've seen a lot of that lately in practice. So the glue that they use as well can cause a severe contact dermatitis. And as I mentioned, this is mostly going to affect the eyelids themselves. So as you can see, there's a lot of different issues, or a lot of different types of conjunctivitis, allergic conjunctivitis that can happen. The main issue, again, is under misdiagnosis, under treatment. Patients go into an aisle in a pharmacy and they see this type of thing, where there's so many different options and only 10% are coming to their provider. The treatment is actually poor. Like I said, it's primarily self-diagnosed. There's a lack of understanding of the broad nature of allergic symptoms and the link between different allergic disorders. And in primary care, they're limited. They have a limited approach to the management. So there's definitely a huge need for a clear diagnostic criteria for primary care. And I think this is an important part for us to, again, connect with different primary care providers, connect with allergists as well, to improve overall care of these patients, because so few of them are actually making it to our practices. So we need more advanced guidelines for subspecialists to refine differential diagnosis of anterior ocular surface disease and allergy versus dry eye. Like I said, there has to be a little bit better co-management between allergists and eye care specialists to maximize patient outcomes. So actually, according to studies, allergists underdiagnose dry eye and overdiagnose ocular allergies, which makes sense because they probably think, all patients with red eyes have allergic conjunctivitis, whereas we actually overdiagnose allergic conjunctivitis, but we undertreat it. So this has actually surprised me when I found that information. And I was thinking, how is it possible that we are diagnosing it so much, but we're not treating it? And is it because we're kind of just putting it off to the side? Is it because we're not putting enough importance on it? Or are we just focusing on glasses, on contact lenses? This is something that we have access to treat, that we know how to treat, that we know how to diagnose. And I really believe that we should be treating it properly. We have access to so many different options, again, for treatment. And primary care providers underdiagnose and undertreat or mistreat allergic conjunctivitis. So they often will treat patients with corticosteroids. So as you know, ocular corticosteroids, it will work. It will decrease inflammation, which is ultimately what we're trying to do. But We know this is a short-term treatment. It's not identifying the underlying cause. And it's also not preventing mast cell destabilization, which is what we're doing with a lot of the drops that we're using. So you can use a topical corticosteroid, but they're mainly using this. They're not doing the patient's service, because if the patients continue being exposed to the allergen, then they will continue, even after discontinuing the ocular corticosteroid, they will continue or start again to have symptoms, and it won't go away. So the key to treating allergic conjunctivitis is identifying what it is. So properly diagnosing what, the type of allergic conjunctivitis, and then ideally eliminating the allergen completely. So I'll take questions now, if there are any.
Great. Yeah, so we had a few questions from the audience. One in particular was about, some of the hypersensitivities that people may have, or allergies to different ingredients in contact lens solutions. Thimerosal, I don't think is in too many solutions. Have you found different with maybe some like the generic options?
I try to keep my patients off of generic as much as possible. I don't think thimerosal is used as often at all anymore, but I think it's important for us to know what thimerosal is and why it should not be used. And the reason is because it has such a high rate of delayed hypersensitivity reactions.
Mm-hmm.
BAK though is used quite a bit, and the thing with BAK though is it might be hard to differentiate between the toxic reaction and or the tear film kind of reaction you may have, and then the delayed hypersensitivity. So is it an allergy that the patient is having to the BAK, which could be, or is it more of kind of a dryness, tear film deficiency, just irritation? So it's important to, I guess, differentiate, because dryness can be like, if a patient is allergic to it, I mean, obviously it should be discontinued. If a patient is getting irritated by it, that can be, I guess we can supplement with an artificial tear or a gel or something in between type of thing.
Okay. Yeah. I loved your tips on how to differentiate between dry eye and allergies, because that is, as you know, a hard thing to do.
A lot of the time, they come in with both of them, and you might find that they have both, but it doesn't mean one or the other should be treated. Both of them should be treated. I tell this to my patients: inflammation plus inflammation is even more inflammation. So we're trying to decrease inflammation, whether it's allergic or dry eye. You can do both in tandem, and I think that's important.
For sure. When you see patients that have allergic conjunctivitis, do you ever see it be a asymmetric appearance, or should it mostly be symmetric between the two eyes?
And one thing I do with my patients is I ask them what side they sleep on. Mm-hmm. And every time I see an asymmetric allergic conjunctivitis, I ask which side they sleep on. And a lot of the time it's the side that's irritated. And what's interesting about that is it makes you think of, okay, there's something inside the bed? So it could be laundry detergent, it could be dust, it could be like the material of the pillowcase. I mean, it's a lot of educated guessing. As I mentioned, we don't have a lot of tools in eye care itself that can help identify what the allergen is. But that's where co-managing with an allergist, if you see a lot of allergic conjunctivitis in your practice, it's so important to try to identify what the allergen is, because people can't be on mast cell stabilizers and antihistamines forever. I mean, very low side effect profile. I would absolutely advocate that, but it's hard to put a patient on a drop forever if it's not a glaucoma drop type of thing. Even that's hard. So imagine imagine allergic conjunctivitis. So I really do think elimination of the allergen is key. And the only way you can do that is by identifying it. The bad thing about these type of tests is that sometimes they come back and so non-specific. It's like everything that they're allergic to.
Yeah.
So, they're allergic to every type of dust and dander. It's like, how do you even get rid of that? So that's the frustrating part about identifying allergens.
For sure. So as far as contact lens wear is concerned with allergies, do you typically prioritize a hydrogen peroxide system over multi-purpose solutions?
I prioritize daily disposables.
Yeah.
Like, but
Drop
yeah.
the mic.
But yes, so if we're talking about disposable contact lenses, so non-specialty contact lenses, I definitely will do whatever I can to get them into a daily disposable. If they're in a specialty lens that's not disposable, obviously I will try to go for a hydrogen peroxide solution. No preservatives, so you're eliminating, just their exposure to things like BAK or thimerosal. If not those, then other preservatives that can cause delayed hypersensitivity. But also just chemicals in general, which can dry out the tear film and increase the exposure to other allergens. So definitely, hydrogen peroxide. Short answer, long answer. Yes.
That was a great answer. Daily disposals all day, every day.
Yeah.
What about allergies to topical anesthetics and bromonidine?
Yeah, I mean, listen, it's if you have to identify whether it's toxic or allergic. It's very different. It's a very different presentation. If it's allergic, flip the eyelid, you're going to see papillae, you're going to see chemosis. All right, so edema of the conjunctiva, which again, I'll show a picture of what that looks like when we're talking about chemosis. This is what it looks like. When you look at a toxic reaction, you're seeing just a lot of irritation of the cornea. So a lot of diffuse corneal staining is what you'll see with the toxic reaction. If you see, what was it, brimonidine and what was the other one?
Topical anesthetics.
Yeah, write it down, document that for the patient and make sure that it's not used again. All of my patients on my EHR have a list of allergies. And if I see that they have a reaction to it, then I will not use it again. For topical anesthetics, there are higher kind of molecular, fluorescein anesthetic kind of mixes like binoxidate or combinations that are different than proparacaine and can cause less reaction. So I would switch to that. So that's always good to have. And another one for brimonidine, I mean, there's a lot of different options for glaucoma drops. And if I'd switch to another one or co-manage with a glaucoma specialist and definitely switch. You do not want to keep a patient exposed to anything that they're allergic to.
For sure. Yeah, especially with all those side effects that you talked about, the long-term consequences. This doctor had a question about if you've had any experience using Vercasia for vernal conjunctivitis and any advice you have on pros and cons or success stories.
No, I have not. First of all, VKC is not that common in my practice. And I haven't seen many patients with it. I've heard of that medication. I'm excited to learn more about it. And hopefully I'll use it soon and have more feedback.
I just did a quick Google search of it because I had not heard of it.
Yeah, it's pretty new. So
that's cool. And then how about prophylactic treatment? Do you have patients just go ahead and start with, antihistamine drops before the season ever begins?
So good question. So antihistamine alone is not prophylactic. There has to be a mast cell stabilizer there if you want it. So if it's just an antihistamine alone, it's only going to work if there's a histamine release, right? So what you need to use is a mast cell stabilizer drop, and there's several of those, and there's combination drops, of course. So yes, if you have a patient that they know that they always get allergies around February or March or whatever, you have them use it about 30 days before. And that is a great way to prevent them from having the reaction. Another tip I have, they're going to a dry climate where they're going to be exposed to allergens. Again, dryness will increase the allergic reaction because you're increasing exposure by having a drier eye. And so they may want to also treat prophylactically. But yes, I do believe that. And a lot of patients will like to do that, especially if they want to stay comfortable in their contact lenses during allergy season and overall just keep their eyes calm. It's excellent to do that.
Perfect. Well, yeah, and it seems like, allergists would be really great doctors to maybe co-manage with and just set up a really good relationship with. Do you have many allergists in your area that you work with?
So one thing I was doing was a few of the ophthalmologists I would work with would do the skin prick test in the office, and they would be able to identify what is causing the conjunctivitis. And the feedback I got, and the reason I don't do it too much anymore, is because it was just so non-specific. It was like, my patient would come back and be like, yeah, I'm pretty much allergic to everything. And so it didn't really help too much. I think probably it's good to work with an allergist who can do more specific tests like this one, patch tests, and delineate specific antigens. And also just help identify what it is, especially if the reaction is really severe, because, especially if the patient wants to wear contact lenses just to keep them comfortable wearing contact lenses, it's so important to identify what is causing the reaction.
Yeah, for sure. Well, this will be our last question, and that is performing cold compresses during allergic conjunctivitis. And I kind of want to add on to it, what if you have a patient that is a severe dry eye patient and you have them on warm compresses, for example? What do you think about that?
So warm compresses are not my favorite treatment. It's a great treatment for meibomian gland disease, don't get me wrong. The problem is that it heats up the entire eye, right? So it increases inflammation overall. I much prefer to do an in-office procedure for dry eye, like meibomian gland evacuation type of treatment. And then they may not have to do warm compresses as often. And the good thing about those in-office treatments for dry eye is that you can really direct the heat exactly to the meibomian glands rather than the entire eye. So you would not exacerbate allergic conjunctivitis. I find that a lot of patients who have simultaneous evaporative dry eye and aqueous deficient dry eye don't do that well with hot compresses, because the actual inflammation increase caused by the hot compress will just make their eye more inflamed, even though it's helping the meibomian gland. So I am a big proponent for cold compress if they are more aqueous deficient than evaporative. I am a big proponent for cold compresses for allergic conjunctivitis. And one tip I really have that's a good one is I tell patients to put their allergic conjunctivitis drops in the refrigerator, and that will allow them to get a cooling effect, which will really help as well, or further, reduce inflammation.
For sure. Yeah, I saw I forget what CE I was attending, but they showed, I guess, the inflammatory cells in the eye before versus after warm compresses, and especially in patients that had lid telangiectasia. It was pretty interesting.
Oh yeah, for sure.
Okay, really the last question. Another one came in. The question is, how do you treat acute periocular contact dermatitis prior to identifying the allergen?
Good question. This is definitely going to use a steroid for contact dermatitis. It's the patients are very scared when they come in with that. It's pretty. Sometimes the reaction can be pretty bad. Um, let's go back. I mean, the one I have a picture of is not so severe, but no, that's atopic. But it can be pretty scary for patients, and so I want to help just calm it down. But I really do think you have to identify. So a lot of time you can identify this by asking patients, did you use a new cream? Did you use a new mascara? Did you use a new laundry detergent? Is there something new? Did you just get a pet? And hopefully it's not the pet because that would be really sad. But, and a lot of them will be like, yeah, actually, I just got a new cream, or I just started using this oil on my face, and that's what it is. Throw it away, and it works. So a lot of the time you can identify just by asking the right questions. But definitely a corticosteroid in this case, something that is ophthalmic, because if an ophthalmic cream, because it can get in the eye. So I try to stay away from hydrocortisone like cream, because again, ocular contact is very common or very likely in these cases.
Sure. Well, cool. Well, I think that is it for now. Thank you so much for the awesome presentation.